afternoon from Israel, Europe. Good morning in the States. And today is a very big honor for me to introduce our lecturers, Dr. Meizi Eliezer. And Meizi graduated in Jerusalem and did a master in Tel Aviv and did a post specialist program in Zurich, Bern, Switzerland. And I can tell you a lot of, she's lecturing around the world quite a lot. Every time that I call her, she's somewhere else around the world. But I think the most important thing that in her CV, for us at least, she's a very long time member of Alpha Omega. She's currently the president of the Tel Aviv chapter. And I asked her to be responsible for our continuing education program this year. And she did a marvelous job together with me together. We create a wonderful program. And we asked her to help Sharon next year. And she really agreed. And I'm very thank you for all what you are doing for us here in Israel in Alpha Omega. And since you are so famous lecturers, so we are willing to hear your lectures, and I won't disturb you too long. So Meizi, the stage is yours. The screen is yours. You can share your screen and let's hear you.
Thank you very much. You can see my screen. I'm already sharing it, yeah?
Yeah.
You can see it. So thank you very much, Eldad. This is honored to be, I'm very honored to be here and very excited. I love Alpha Omega. I've been with Alpha Omega since 2003, and it's always a pleasure to be here among our friends worldwide. And today I want to present this subject that more and more in the world they are talking about it, the wire syndrome after orthodontic treatment. Today I want to discuss how we can diagnose it and how we can treat it. Wire syndrome is it's a new diagnosis that start to develop for the past 5 years, and due to the fact that we have more orthodontics treatment, we could see this syndrome coming more and more on young patients after from 1 year till 10, 20 years after orthodontic treatment. And what I want to say to you, which is very, very important, we need to diagnose it as soon as possible and not to ignore it. Because if we ignore it, it's going to progress. And when it's progress sometimes fast and very radical. So what I want to mention today, please do not ignore it. If you see what you learned today about the wire syndrome after orthodontic treatment, please refer the patient or treat it. Today I will teach you how we can treat this kind of syndrome. So before I start the lecture, I want to say that I have no conflict of interest. Nobody pays me to give this lecture, and also I don't get paid by companies. And this is real clinical photos that I present here. There is no Photoshop in my presentation and in my picture that I published in my website or in the Instagram. I never do something like that. This is what a picture is, what you see, and that's very, very important to clarify it. I want to also to tell you that I have a YouTube channel that's called Periohome. Over there, you could see my videos, surgical videos. How do I treat if it's a recessions, if it's periodontal regeneration, implants, procedures, peri-implantitis cases, extraction in the aesthetic zone, all of those. There are lots of videos for you for free to see and watch. I also talk there and share my instruments, like what instruments I'm using, what kind of materials. So if somebody wants to follow, he can know exactly which materials I'm using. And of course, I have Instagram channel that's called Periohome, and LinkedIn, and also Facebook. So if somebody would like to follow me, there is here like you could see here this scan. You can scan this code, and please, you all welcome to see those videos. So, orthodontic side effects. So, orthodontic treatment are so popular in Israel and I'm sure worldwide. Every second child that I see had a bracelet and or with orthodontic treatment. Some patients are already going through second and third orthodontic treatment to correct their smile line, their alignment, and all other thing that bothers them in order to have a nice aligned smile. The aesthetic desire today for patient is really, really high. They have high demands. So that's all okay. They can go for orthodontic treatment. However, we need not to forget that orthodontic treatment has some side effects. What kind of side effects do I see in my clinic? So we could see some bone defects, that means bone loss, if it's infrabony defect or horizontal bony defect. We could see recessions after orthodontic treatment. Usually it's not generalized most of the time. Most of the time it's or localized or some teeth that align one to next to another that have recessions. We could see root resorption sometimes after orthodontic treatment, and we could see also some black triangles. That a lot of the patient, those black triangles very much affect them, and a lot of the time want to get rid of it, and they go through another orthodontic treatment, so maybe the orthodontic treatment can actually close this kind of black triangle. So those kinds of side effects of the orthodontic treatment is not new. In periodontology, we do treat those side effects. If we have an overgrowth, this is a perio problem. We can treat it. I will show you soon how we can do that. And then if we have a passive eruption, this is something that happened after orthodontic treatment. There is an altered passive eruption that because due to the fact that they want to close the, let's say, the open bite, or maybe they take the teeth and get it more and force the teeth to close this open bite, then a lot of the time the bone and the periodontal attachment attach to those area and pull together everything down. And you could see in the smile that the teeth become round, very much small size of teeth, and of course aesthetically unpleasant. And some of the times when there is an orthodontic treatment, they pull the teeth out of the bony envelope, and when it's happened, then a lot of the time we see recessions, and there is a problem with sensitivity, and sometimes even with loss of vitality. So let's see how we treat some of those side effects in periodontology. So if we have gum overgrowth of the gums, like here with this young patient, 16 years old, that was sent by his orthodontist, it's very unpleasant for him to look like that. So his orthodontist sent him to treat this kind of overgrowth. And what is the treatment? This is, of course, crown lengthening, including bone reduction, because without the bone reduction, we cannot get this kind of results. You can do gingivectomy, but it will not last. So we have to do also ostectomy. That means to do vestibuloplastica, to reduce the bone, and to make it even with the gums. So this is a 16 years old that his overgrowth after orthodontic treatment was solved with crown lengthening. And then if we have a horizontal bone loss or infrabony, in this case it was almost infrabony bone loss, because you don't see so much the bone here, but there was some wall on the palatal area, but it was a very deep pocket here, 10 millimeters of pocket. And then you could see after regenerative procedure, you could see the bone here. Yes, I implanted bone, and I also put some regenerative material like Emdogen, and you could see here the bone growth, okay? And in this case, you could see that we can have periodontal regeneration after periodontal treatment, although after orthodontic treatment, we could see this kind of bone loss, this kind of bone defects. And then another side effect of orthodontic treatment, this is the wire syndrome. The wire syndrome becomes so popular that I'm sure you see this phenomenon in your clinic. Only 31% of general practitioners are familiar with the wire syndrome, unfortunately, which indicates a notable lack of awareness of this phenomenon. This is something that was discovered and was published in 2022, that when they did questionnaire about this syndrome, only 31% of the general practitioners know there is something like that. And this is why I'm coming today to you with this lecture. So the awareness of us, general practitioner, dentists all over the world, could detect it. And even hygienists can detect this kind of problem and send the patient for a treatment. So you could see here all kind of patients that came into my clinic, all has a wire after orthodontic treatment and all have recession. And you could see some irregularity with the alignment of the teeth. So you have something similar with all of those patients. So what is the definition of the wire syndrome? This is unexpected tooth movement. Suddenly a tooth is moving, although there is a retainer. It's occurring despite the presence of intact bonded orthodontic retainer. That means that if the retainer is not bonded, this is not a wire syndrome. Okay, it has to be a retainer that is cemented and bonded on the lingual area of the lower teeth, and it causes to gingival recession, as we could see in those two pictures. The prevalence of the wire syndrome was studied in a few studies. One cohort study of 3,500 patients, 38% exhibit a wire syndrome. That means the prevalence was about 1%, which is, if we think about it, it is a lot, because 1% of the whole population, that is a lot. Another study have shown that in dental students that went through orthodontic treatment and have a wire, had this wire, then over there we could see 9 out of the 59 students experience wire syndrome. That means 15% of those have a wire syndrome. And then another study, although the sample size was small, exhibit 27% of wire syndrome in those patients. So let's say it's growing. This phenomenon is growing more and more around the world because there are more orthodontic treatments. So if we look in why it's happening, what is the risk factors for developing the wire syndrome, then Carole Charvet was doing a study about why it's happened, what is the common with all those patients that makes maybe this kind of phenomenon to appear. So she has been shown that all of those patients that has the wire and has recession has some similarity with the profile. They all have some concave profile. They all have a multi-strained round wire, as you can see here, and they all have a deep labiomental fold. Okay, on that three risk factor, they did also a multivariant analysis that confirms that those are actually significant associates with the recession, is significantly associated with the wire syndrome. Those are the factors those are the risk factors that associates with the wire syndrome, except the concave profile. That was in the multivariant analysis, was not significant. This is actually was very interesting to see this study that was published by Carola in 2024, because we have published a group that I'm doing over there, my PhD, the Mishwara group. Over there, we have studied something very interesting about the correlation between the angulation of the anterior lower teeth and their angulation and the recession. What is the correlation? Is some angle are more prominent to develop a recession? Then we have seen that the smaller is the angle, that means the deeper is the angle, then the deeper is the recession, like Carole was proven. She looked on this fold, but on the cheek fold, on the this area. I looked on the teeth area, which is also some correlation to that fold. So the smaller the angle, the deeper is the recession. As you can see here, we measured two angles, the one from the tip into the mental bone, or the one that align parallel to the bone into the mental bone. And then we measure those two angles and compare it to the parallel teeth that had no recession, and wanted to see if there is some correlation. And this is the correlation that we have seen. So the smaller the angle, the deeper is the recession. But we also concluded that the angulation is not the primary factor of the gingival recession. That means you cannot say, okay, patient has this deep angulation or smaller angle, that means he will develop a recession. No, it doesn't mean that. It means that if we have a smaller angle, we might see a deeper recession. And there are probably more factors to develop the recession. So what is the gingival recession? It's actually a displacement of the gingiva from the CEJ to the apex of the teeth. So every time we see the gingiva go apically, then the root is exposed. We can say this is a gingival recession. It can be localized or it can be generalized. It can be in different sides. We can meet it in the buccal side or in the lingual side or in the palatal side. And what is so important to understand, once we see recession, that means there is a loss of clinical attachment. And this is something to remember. Now, the etiology for recession is, we have multiple, variable for this kind of why it's developed. It can develop due to the fact we have root proximity. It can develop due to the fact we have some, some piercing that knock on the teeth, and that can cause the recession from very hard brushing, to orthodontic treatment, to frenulum, to plaque and calculus accumulation. And this is something that we need to remind, that the etiology, it's multifactorial. That means there is lots of factors why these kind of recessions happen. Today we're going to talk about one of the factors. This is activating the metal retainer. Okay, the metal retainer, it has some responsibility for developing of the recession. Now, before we can go through this lecture, we need to understand how to define our recession. What is the classification? So here we could see Cairo classification for recession from 2011, and he has talked about recession type 1 to 3. And what is the difference between them? Recession type 1 means that the gingival recession has no loss of attachment in the interproximal area. That means no tissue loss in the interproximal and no bone loss. And only we have this kind of recession. Then this is RT1. The RT2 means that we do have some interproximal loss of bone and tissue, but it's smaller than the clinical attachment loss in the buccal area. So we measure the interproximal, we measure the buccal area, and we see that the buccal is bigger, the recession here is bigger than the interproximal clinical attachment loss. And if the interproximal clinical attachment loss is smaller, then it's called RT2. Once the interproximal clinical attachment loss is bigger than the buccal one, that means this is RT3. Now, it's very important to know that, because the RT1 and RT2 are something we can treat, but the RT3 is something that we cannot treat it with just recession coverage, and it's not predictable. And also we need to understand that if we have RT1, then we will have a higher mean recession reduction. That means more option to recession coverage versus the RT2. Gingival recession can happen while we have an active orthodontic treatment. That means in the middle of the orthodontic treatment, the patient develops some recession. For example, here you see a patient that came to my clinic in the middle of orthodontic treatment with Invisalign. You can see here the attachment, and this patient developed recession. Then we could also have recession while the orthodontic treatment is finished and the patient have fixed orthodontic retainer. As you can see here, this is a young patient in her 18 years old. After she finished orthodontic treatment, you can see here a little bit the retainer that she has on the lingual side, and she developed a recession. So gingival recession can happen during orthodontic treatment or after orthodontic treatment. So what are the purpose? Why we actually giving our patient retainers? So of course, this was logic for us that we don't want a relapse of the teeth. The teeth was crowded or was not aligned, and we would like to prevent a relapse of the situation that the patient came with. So to prevent a relapse, and then to maintain the alignment, the post-orthodontic treatment, we want to maintain it. So we put this kind of retainer. Now, we have a few types of wire-bonded fixed retainers. One of them is multi-stranded wire retainer, which can be braided or twisted wire, as you can see here. It could be a round or straight stainless steel wire retainer, okay, as you can see in that area. Or it can be a custom-shaped or preformed retainers that can be sent by the lab. Now, the wire syndrome phenomenon was a group with Carole and Sophia Roca, I don't know if you know them, and Miriam. They are very well-known periodontists and orthodontists, and they have published a systematic review about the wire syndrome. Over there, they wanted to investigate how the wire syndrome connect to the recession that we are seeing in our daily practice. And then they find here that the wire syndrome is a whole range of situations in which one tooth or several teeth are connected to each other by bonded wire and present suddenly unwanted movement. And this unwanted movement caused to the recession. It can happen in the incisors and the canine, and every wire can have a wire syndrome, because when they investigated it, they saw that in the systematic review, they saw that every wire was participate in this kind of development of the wire syndrome. And it can happen immediately after orthodontic treatment or many years after orthodontic treatment. So it doesn't mean that if somebody finished today and he has no recession due to the wire syndrome, he won't develop it in 10 years' time. And I also mentioned the hypothesis development around this wire syndrome. One of the hypotheses was the intrinsic one. They say that the bonded or rebonded wire is actually active and exerts a force on the teeth. So that means the wire is the cause of the movement of the teeth and cause to the wire syndrome, goes to the recession. So the wire get active and that affect teeth movement. The other one is the extrinsic hypothesis. That means that the wire is passive, he has no forces on it, but the teeth that connect to the wire move under the influence of an external force. For example, like the tongue. The tongue has it's very strong, as we know, and it can cause to external force on the teeth itself, and the wire is not to be blamed because it just sits there passively. As you can see here with this patient, that the tongue pushes the teeth over here to the side. So the wire syndrome is something we need to understand. If there is a sudden break of the retainer, there is probably something that moved the teeth. Okay, so the retainer was broke due to the fact that the teeth was moved somehow, and it break from the adhesive. That means that it's an external force that forced the teeth to move, and the wire cannot hold anymore the teeth itself, and the tooth is the tooth is rotated around the wire, and then you could see that it pushes into the buccal area and recession is developed. And they defined, if we have a wire syndrome, do we need to have a re-ortho treatment or not? So they have set 3 kinds of classification. The first one is to look on the coronal part. If there is only the third coronal is with a recession and 1 millimeter outside of the bony envelope, as you can see here, and the tip is within the bone, as you can see here in the CBCT, that means that we're going to have 100% recession coverage, and we do not need an orthodontic treatment. We don't need a re-ortho treatment. Like this patient that came to my clinic, and you could see the before and after. It's exactly in this kind of characteristics, and I did a recession coverage, and already 5 years after, she still have this kind of results. And then if we look of the recession itself, which is 2/3, yes, we could see here, it's 2/3 of the root, and then we could see 2 millimeter outside of the bone envelope, as you can see here in the CBCT. The tip is still within the bone, then we might get a partial recession coverage, which is also fine, that can give a good result, and still no ortho treatment needed in that case. As you can see here, a patient that came to my clinic, you can see the recession, and then you can see the results. It's already also 5 years. Yes, there is a 0.5 millimeter of still recession here, but it's still good results, and the patient can live with it. Now, if we have that, you could see that almost, you could see the whole root. You could see that the tip of the root is not inside the bone, part of it is outside of the bony envelope. That this kind of situation must have ortho treatment. That means it needs to do re-ortho in order to push back this root into the bony envelope. But I have to say that sometimes the orthodontist asked me to cover and to do recession, even if this kind of root is outside of the bony envelope. And I do have this case that already 5 years after finishing, that she has a recession coverage, not 100%, but 80%. And it was, even though the root was outside of the bony envelope, she still got very good result. And the orthodontist feel more secure to push these tooth more to the lingual area, because there is some gums that covers this kind of recessions. Now, what is the treatment that we can do when we have the wire seam? What kind of treatment? So we could see this is a patient that came to my clinic with a tooth that was wired. There was a wired here, and the wire was broken. The doctor was re-cement the wire, and suddenly she felt that the gums start to be receding. And only that tooth start to recede. You could see that the crown is pushed a bit to the lingual, but the root is more buccally, and you could see the adjacent teeth number 41 is going more, the crown goes more buccally, and you could see also the other teeth suddenly start to be not aligned. So this is due to the fact that the wire was re-cemented, and then suddenly the recession was appeared. So she was sent to my clinic. It actually was a very nice story that I couldn't treat her, and then she went to another periodontist. The periodontist did the recession coverage. It wasn't successful. You could see here she has some scar tissue around it, and then she came to my clinic, and I have done a recession coverage. And you could see here she's already been followed here in my clinic more than 2 years. And you could see how much tissue she got. Now, the fact that she has not 100% is not a problem, because this kind of situation can be maintained also forever and there is no problem. Also, you could see that the tooth is a bit more coronally, has a more erupted compared to the other teeth. So that is also causing the fact that we could see more root. And I have to say that about the wire was changed before I did the recession coverage, because the wire was not good. It was keeping forces on that tooth, and every day this patient showed see that her root was more buccally, and the recession is getting larger and larger. So the first thing I did is change the wire. The second thing I did, of course, after seeing that you cannot push the tooth more lingually because there is no bone over here on the lingual side, then I did the recession coverage. So diagnosis of the wire. So wire, first of all, is to wire removal. If you have a wire syndrome, remove the wire. Then perform non-surgical treatment. That means if she has some inflammation or plaque, or needs to have an oral hygiene instruction, please perform it. And then see if there is any parafunction on the tooth itself that cause more force and more problems. Then when you fix all of that, you control it for 3 months. After you control it for 3 months, you also do cleaning and you do control of the inflammation. Of course, that we don't want inflammation during this time. And then you need to decide if you want to go through ortho treatment or you want to go through a root coverage and changing the phenotypes. Or you could do ortho treatment first and then going for root coverage and phenotype modification, or you go for root coverage, phenotype modification, and then orthodontic treatment. But what I want you to remember, that first of all, if you detect a wire syndrome, please remove the wire. Then perform some non-surgical treatment, scaling and root planning, or just scaling and oral hygiene instruction, how to clean properly in the area of the recession, which sometimes can be very, very challenging because it's sensitive to the patient. So we need to take soft toothbrush without toothpaste that is abrasive, no abrasive toothpaste, please. And you need to teach them how to brush from apical to coronal. Okay, so we won't have more recession, and of course to check parafunction. This is an example from the article that you could see in 2008. You could see this tooth that was rotated, the canine was rotated buccally, very much buccally, and you could see here in the lingual side, the root is more lingually, we could see it here, and then they took out the wire, as you could see here, and they left it, okay? And then they follow it for 1 year, and without doing any ortho treatment, you could see the tooth start to come and come correctly to the place. What is the treatment that we can do? We have a non-surgical treatment, and we also have a surgical treatment for recession. Now, the non-surgical treatment, as we said already, we need to correct the tooth brushing, to remove any habit piercing, to remove the retainer, it's part of it, to correct the malocclusion, to treat dentinal sensitivity with maybe put a varnish of fluor, remove the calculus and plaque, and give right oral hygiene instruction. And then if we remove the retainer, and there is a very nice article by the group from Tel Aviv University with Rachel Sarig that was already gave a lecture to the Alpha Omega in London, and with the group of Ilan Bittentum, then we could see that if we remove the recession prior to the recession coverage, if we remove the retainer prior to the recession coverage, we will yield a better result for our recession coverage in Miller class 3. This is a very important conclusion, because if we see how wire syndrome, if we remove the retainer and perform a recession coverage, we will gain better recession coverage. What kind of treatment for recession coverage? Surgical treatment. We can have the tunnel root coverage techniques. That means we can have modified coronally advanced tunnel or laterally closed tunnel. Both of them are for recession coverage without cutting the papillas. We are just creating the tunnel. In this kind of situation, in the tunnel technique, we have two sides that we are operating. We have the recipient side, the side that we create the tunnel, and we are going to implant the subepithelial connective tissue graft. And also we have the other surgical side, which called the donor side, which this is where we harvest the tissue. My technique is to do it with subepithelial connective tissue graft. That means I'm doing an incision, taking the connective tissue under the epithel and suturing the epithel so the patient will have a faster healing. And then if we have a subepithelial connective tissue graft, or we have a free gingival graft, and then we can cut the epithelium and take the connective tissue itself. Those are the area in the donor side that we need to understand from where to take the connective tissue. Usually we take it from the 6th till the 3rd teeth on the palate side. So here are some examples that all of them was treated in the tunnel technique with connective tissue graft. Some of them I added Emdogain, and some of them I added cross-link hyaluronic acid. And you can see here Miller class 3, how deep is the recession. I did a CBCT and I saw there is no lingual bone, so I cannot send him to the orthodontist to do another retreatment. Here you could see the result of the recession coverage after 24 months. And this is something that the patient can brush on and can keep this kind of results. Then there was another patient that came in time of the orthodontic treatment. You could see the recession also developed some pocket, and you can see after 1 month the recession coverage results with very good results, and after 4 months she could continue with the orthodontic treatment. This is another patient that you could see the recession. You could see also a little bit connection of the frenulum, and you could see that she has no lingual bone to push the tooth into. And this is after 36 months of follow-up. You could see the recession coverage of this patient. She came after orthodontic treatment, retreatment of orthodontic. The orthodontist did a very good job by pushing as much as he can the roots, and you could see the recession coverage that I've done after it. Another patient that you already seen, you could see here, this is a Miller class 3. You could see the root is about 15 millimeter. We could see the root. There is another, let's say, a fracture of the gums here that we could see more of the root area. And this patient went through first the recession coverage, and then I was recommending her to go to the orthodontist to push the teeth into the lingual area, into the bony envelope, due to the fact that this tooth is very much pronounced buccally, and we have a nice bone lingually that the tooth could be pushed back to. Another Miller class 3, you could see the bleaching of the roots. The root sit very, very much in the buccal side. And then this is after the orthodontic treatment. This is 5 years follow-up. We will see the video of this case later on. This is another case. You could see the results, a young patient after orthodontic treatment. And then I want to show you how we have this wire syndrome that happened and how we treated it. So this patient came, she has a recession. You could see the movement of the teeth. Here I'm marking how much tissue I need from the palate area. The subepithelial connective tissue graft, I marked it. I'm doing an incision parallel to the teeth, then taking the subepithelial connective tissue graft, taking the connective tissue graft under the epithelium, with 15C blade. And then I'm suturing it, not before I'm putting some collagen. Dip with cross-linked hyaluronic acid, and I'm suturing it. I'm always suturing with nylon sutures because I want them to stay as long as possible and give a good adaptation of the tissue. All those videos are in my YouTube channel. You can watch it freely whenever you want. You can see there is still a line, so I'm going to suture more to close this gap. And then I'm adding cross-linked hyaluronic acid. Then I'm creating the tunnel. Make sure that everything is free. I'm adding the connective tissue. Doing it in a tunnel technique way. Double suturing on the tissue itself, the connective tissue itself. And suturing from both sides, adding cross-linked hyaluronic acid that was proven to help in regenerative procedure, including in recession coverage. This is a study we have done. And then suturing everything coronally. This is modified coronally advanced flap, together with laterally closed tunnel. So this is both of the techniques. And then suturing everything. Let's progress. So how we need to think when we see gingival recession between 33 and 43 with the wire, okay, with the wire retainer. So we need to look at the canine and the incisive. If they are not aligned, like in those situations, you could see here the canine, the incisive is not aligned with the tooth next to it, and this is not aligned, and the tooth here 41 is not aligned with the canine as well. There is some movement. then we need to send to CBCT, as you could see here that I've sent those patients. If they are not aligned, then we know that this is a wire syndrome. And if it's a wire syndrome, we need to perform situation to change the wire, and I will show you else what to do. If it's aligned, that means the teeth like here are aligned and they still have recession, and the CBCT, we send to CBCT, and the CBCT show there about the lingual bone that we need to look at. If there is a lingual bone, then we need to consult the orthodontist. If there is no lingual bone, then we need to think about maybe to cut the frenulum, as you could see here, to do a frenectomy, to look at the frenulum. If there is a frenulum, if there is no frenulum, that means there is no connection of the frenulum, then we do straight on recession coverage. If we have a frenulum that attached to the free gingiva, then we do something called frenectomy. As you could see here, this is a frenulum that attached to the free gingiva and caused to recession. And then after frenectomy, the recession is start to close. So we don't have to do here recession coverage. If we detect it's a wire syndrome, then we need to remove the wire and wait for 3 months. And then to do reevaluation and think if we need a recession coverage or orthodontic consultation. And also don't forget, we need to renew the wire. Always renew the wire after the removal after 3 months. We renew the wire, we need to send to CBCT, like in this situation, for example, I removed the wire, but I couldn't leave it without a wire because the tooth was too mobile. So in this situation, I renew the wire and I send her to CBCT and follow what I showed you. I looked if there is a lingual bone, I saw there is no lingual bone, I looked at the frenulum, in that case, there was no problem with the frenulum, so I did a recession coverage in that situation that you've seen before. So here is a situation. You could see here a patient came, I did a CBCT, I saw those teeth, and I also saw this frenulum that attached very much to the free gingiva. I did a frenectomy. You could see a little bit of scar formation. It's not so prominent, but you could see a little bit, and then I did a recession coverage. And this is 8 months after recession coverage. And the patient was very happy because he went through the way I instructed, as I showed you before. This is the same way. So I changed the wire, I did a frenectomy, I waited for 2 months, then I saw that everything was good, the free gingiva was not attached anymore to the tooth. I did recession coverage, and this is the results that we have. Let's see another video. This is a recession coverage with endogen, so you could see the 2 teeth are very much prominent into the buccal side. First of all, I'm cleaning the calculus, which we know that it's very hard to maintain a calculus free in those area. I'm taking my blade. This is a micro blade. It's a special blade, that it's very, very thin one. It's 180 degrees cutting. And then I take the tunnel instruments and make sure to prepare the tunnel itself without cutting those papillas. The more uncutting the papilla, the more blood we could have. That means that there will be no necrosis, because the blood supply comes from the papilla's area as well. And we prevent from opening those embrasures if we don't cut the papilla. Make sure that everything is very much unattached here. You could see I'm checking if there is no fibers attached. I could see that I could do the laterally closed tunnel. I'm cleaning and debride also the root on the buccally. I'm measuring how much tissue I need. I'm pointing out in the measurement from where to where I'm going to cut and take the tissue. I'm making a cut, and then I'm taking out the connective tissue. I'm putting here also collagen sponge, and I'm suturing it so everything can be healed fast. The patient doesn't feel pain. After 1 week, he comes for suture removal from the palate. Usually everything is already healed. As I say, I'm suturing it with nylon. Then I make sure to take another 6-0 suture, and I'm taking the tissue and inserting it into the tunnel. It comes through the area of the gums, you can see here. And when I pull it inside the tunnel, it's pulled. You can see how it comes inside. And now I'm suturing another edge. Everything under the tunnel. I'm adding, you will see soon, I will add, now I'm suturing the connective tissue to be very firmly attached to the root surface. I'm adding endogen between the tissue and the root surface. And now I'm performing the laterally closed tunnel. This is 6-0, 11mm needle, which is very thin needle. And everything done with microsurgical kit of tunnel instruments. And then you could see I'm suturing the other tooth, the other gums around the laterally closed tunnel, and I'm also do some coronary advanced tunnel. And here I added some more endogen, and you can see I see that everything is stabilized. There is stability and nothing is moving. It's very important to keep stability. So my take-home message for you is to be aware. First of all, it's very, very important when a patient comes for a checkup, for doing some filling, for a crown, please be aware. Check the wire syndrome if you see some wire in his mouth. Then the wire syndrome is not a relapse of orthodontic treatment. If the patient say, oh, I need to do another ortho treatment, and you see this wire and you detect the wire syndrome, this is not a relapse. This is due to the fact that this wire or factors that affect the wires can cause to the movement of the teeth and then to the recession to develop. So we need to remove the causing factor and eliminate them. It can also be treated by mucogingival surgery or ortho or both. So we need first, if we see a wire, to take out the wires and to renew it, and then to understand if we want to go through first orthodontic treatment, retreatment, or to do first mucogingival surgery as recession coverage. Send the patient to the CBCT to have more clue about it. And by that, I'm finishing my lecture, and I want to say thank you for my team. I have a very nice women team in my group that I very much love and very much happy with them. They are with me for the past 8 years. And I want to say thank you for Professor Anton Skurian and also Professor Stefan Stratul. They are going with me a long way. And this is in Perio 12, where we won the first prize for the Innovation Award. And here is a group of periodontist to be. They are periodontist in the specialization program in Timisoara University, where I teach them how to perform regenerative procedure, mucogingival surgeries, and of course my kids, my man, and you, the one that listened to me. I want to thank you very much for staying and until now and hear this kind of phenomenon called wire syndrome. And I hope when you go tomorrow to your clinic, you will detect your first wire syndrome, because I'm sure lots of patients come to your clinic and you could see some of them have that. So now you know how to treat it. Thank you very much. And again, if somebody wants to follow me, here is the link. You can scan it and you can follow me in the social media. So toda rabba for your listening. And I really wish Shavua Tov to everybody here. And hopefully we will have a good week with good bsorot tovot. Thank you very much.
Very much. Interesting. One question may I ask you? What
Yes.
age influence do we have? We found it in age.
No age influence. They discovered that age is not influencing the wire syndrome. No, not a factor.
Oh, great.
They checked age, they check if gender. This is not and they checked how much time you had from the finishing of orthodontic, but that was not a factor.
I see. Well, very interesting. Probably most of us see it somewhere in our clinic daily life, and we were not aware about it until now. So it's very important. And can you stop sharing your screen? So I would like to present your certification before we just finish.
Okay. Any questions?
I don't see anyone. It was very clear and very didactic lecture. So Meizi, you still sharing? Jamie, are you there?
Yes, I'm here.
You can stop sharing her screen, and I want to.
Yeah, you can just share it, Eldad.
Okay.
You can stop her sharing.
Eldad, do you want to answer the question?
Yeah, we have two questions here.
I don't see any question.
They're in the chat.
I see. I see they're in the chat. Yeah. Do you want me to read it?
Yeah,
I can read it.
Yeah, please.
Okay, so Lawrence Gettelman asks, since the recession occurs most on the canine teeth, could aggressive toothbrushing be a contributing cause? It can be a contributing cause, but it's not the only cause. So the fact that the buccal, the roots stand very much buccally, plus you have the aggressive brushing, it can cause to recession. So we need to stop the aggressive brushing, but we need also to make sure or to push back the canine into the bony envelope or to do the recession coverage and cover it with gums. And we do need to eliminate the aggressive toothbrushing. And also buccal is defined for premolar and molar area. Yes, I know. For me, buccal, it's mean also labial. That's true. That's true. We can also call the area where is the buccal here. We call it also labial, of course. I learned it. We can also call it in 20 years. 20 years ago, we also call it buccally. But yes, I meant labial. Okay. Can you describe the root coverage techniques or provide an article to read? Thank you. Richard Rappaport, please write to me on my in my email, and I will send you the articles for the root coverage techniques.
Oh, Meizi, okay. I found the question. Can occlusion be a factor? Michael asking for
occlusion occlusion can be a factor, but for example, if there is force that contribute to the push of the, let's say, to the twisted of the wire, or to activate the wire, or to activate the teeth force, occlusion force can be a factor. This is why we need to adjust the occlusion force if there is a primary occlusal bite on the teeth specifically that has the recession. We need to reduce the force on it. Okay, and there is Dina also mentioned something important. Dina means that we have also noticed sudden recession as patients wear S6 retainer. And S6 retainers should be very much passively. So we need to see why it's happened. This is very interesting. If you can, Dina, if you can send me the pictures, that would be interesting to see. And in the United States, it has been my experience that the orthodontist will request graft, hard and or soft tissue before orthodontic treatment begins to help avoid the situation you describe. Yes, you know, in Israel it doesn't happen that they ask before, but unless they see recessions. But if you don't see recession, if you're still asking for a graft procedure, this is something that every orthodontist needs to think about it, and it is his own opinion. But overall, there is no study that shows that if you have a fully gums without recession and you do orthodontic treatment, if you do a graft procedure, that means you won't get recession. That's something that nobody showed yet. And how to get wire syndrome with Invisalign with no wires? How to get, well, after Invisalign, I'm talking, the wire syndrome is happened after Invisalign. And that's happened after the wire is already cemented into the teeth. Thank you. From Dr. Lauren, Perio in Montreal. Thank you very much for your nice comments, nice lecture. What about predisposing factors such as keratinized tissue width, thickness, and gingival biotypes? Maybe educating orthodontists would help preventing recession. Ron Zohar, thank you very much for your comments. Yes, there's something we need to also discuss. Of course, this is something that needs to be talked more. I had only 40 minutes of lecture today, so I cannot mention everything, but about the wire syndrome, they haven't seen connection between the keratinized tissue thickness and gingival biotypes in the developing of the wire syndrome. I showed you the risk factor during the lecture. What was the risk factor they did detect? And Dina said, what do we do when we find the same recession with the S6 wearing retainer? It's a good question. If you do see in this recession, we need to examine why it's happened and then to treat the recessions, of course, to do CBCT and then to see if there is no lingual bone. You decide to do the recession coverage. If there is a lingual bone, then maybe consult the orthodontic treatment to retreat, or just do the recession coverage and see if there is a good result, the patient can stay like that with the gums that we gain around the recession. Marcello asks, prophylactic free gingival graft on thin biotop, does it help? My recommendation and what I perform, I prefer not to do free gingival graft due to few things. One, we do see shrinkage of the free gingival graft and not a full recession. Second, if there is a thin biotype, you can also do subepithelial connective tissue graft to put the connective tissue graft under the epithelium, and it will thicken the area, and you will have a thicker biotype, okay, or actually phenotype. You will see a thicker phenotype for this patient where you have transplant the subepithelial connective tissue graft. This is my recommend. It's more pretty, and plus it's I think that it has better results. Samuel Talmer, can a removable wire retainer cause or contribute to wire syndrome? No, I never heard that a removable retainer can cause it, because it doesn't stay all the time in the mouth. It doesn't force anything on the wire itself, and there is no study that showed it. It's a good thing maybe to do some study on it and then prove it for once and for all. But as I can see, it didn't. I don't know something about that can cause it. Can occlusion be a factor? Yes, as we said, it can be a factor. We already answered this question. How to get wire syndrome with Invisalign with no wire? Sometimes when there is a force on the roots itself, this is not a wire syndrome. What I showed in my presentation, this is suddenly a patient came in the middle of the Invisalign treatment with a recession, but it wasn't a wire syndrome Invisalign. I just show example where we can get recession. We can get it during active orthodontic treatment, and we could do it, and we can get it after orthodontic treatment. That was part of the slide. Samuel, that is, can a removable lower wire retainer cause a wire syndrome? Howley, I don't know about it because, as I said, and as I investigated, all wires apparently can cause a wire syndrome. I do think that we need to go deeper and actually verify which wire retainers cause it and which not. Can you get wire syndrome with Vivera retainer? Again, we don't know. We don't have enough study for it. This is a new subject. And I think during the next 5 till 10 years, we will have more and more investigation so we can know better which wire to use that won't cause recession, wire syndrome, and won't cause recessions. That's it. That's all the questions. I don't hear you, Eldad.
Ask Jamie to share my screen because she's not allowed me to share the screen.
Oh, you can't, it doesn't share.
So can you put a certification?
Absolutely. Just give me 1
seconds.
moment to pull it up here.
Yeah, amazing. Last question.
Yes.
Pick one. First one that you see.
What? The last one that I see, let's see. Another question came along.
Hold on.
I don't see any more questions.
Yeah. Okay. So before we close, and I would like to present you this wonderful certification from behalf of all of us. And I want to wish all of you a new year, Shana Tova. Just about the corner is about 2 weeks from now. We're going to celebrate the new year. So Shana Tova and peaceful and quiet evening, quite a good year for everyone. And see you. The next lecture on the beginning of October will be a wonderful, also a very important lecture from Germany. So I invite you all to
Professor
come.
Anton Friedman.
Anton Friedman is a wonderful lecturer. I heard him in Baden-Baden a few months ago. So I wish you all a new year and quiet evening. Thank you very much.
שנה טובה, תודה רבה.
Thank you, Shana Tova. Thank you.
שנה טובה לכולם. תודה רבה.
Bye-bye.
ביי ביי. ביי ביי.